Hi, everybody. Welcome to CHP 499-599, Sex and Sexuality. I am your instructor, Chris, and today we're going to be discussing adults and sexuality. Let me share my screen so we can get started. Okay. Just a quick trigger warning. We are going to be talking about abortion, reproductive rights, forced sterilization, and sexual assault today. So please do what you need to take care of yourself. Let's get started. So this week's special topic is mental health and trauma-informed care. We'll start by identifying what adult sexuality-related needs are. Then we'll explore some historical and political context relevant to adult sexuality. After that, we'll identify some of the main barriers and key facts in the literature. Then we'll discuss some of the ways sexuality is impacted by disability. Then we're going to wrap it up by diving into an overview of mental health and trauma-informed care. So when thinking about the common life stages that adults go through, we can use our imagination to explore how each of those stages might affect sexuality. For example, how might having kids or not having kids affect sexuality? What does menopause do to desire for sex? What do life stressors like making rent do to sexuality? How might professional pressure to behave a certain way affect sexuality or gender expression? There are endless ways that sexuality is impacted by adulthood. So let's zoom in a little more to some specific scenarios that adults might face that would require our help as health professionals. With each of the following conditions, I want you to keep in the back of your mind intersectionality. Consider how might each of these conditions be complicated by someone's race, age, socioeconomic status, and so on. We'll start with heart disease. Physical limitations of heart disease that cause impact to sexuality are fatigue, shortness of breath, chest pain, and decreased stamina, among others. These symptoms can affect a client's ability to engage in sexual activity or can make sexual activity very uncomfortable. Fatigue and decreased stamina can also make it challenging for people to maintain their relationship routines. Like maybe the person isn't able to do their evening walks with their spouse at night, or maybe they're not able to make dinner with their partner as they usually do. Some medications used to manage heart disease, like beta blockers or certain blood pressure medications, may have side effects that affect libido, arousal, or sexual function. Dealing with heart disease can also lead to feelings of depression, anxiety, or stress. This can negatively affect mental health, understandably, and oftentimes leads to a decrease in sexual desire and intimacy, putting strain on relationships or causing clients to socially isolate themselves. Concerns about having a heart attack or experiencing chest pain during sex might lead to anxiety or fear in engaging in sexual acts. This fear can dampen libido and create emotional barriers to intimacy. Additionally, following heart procedures or from major lifestyle changes due to heart disease, individuals may experience changes in body image, self-esteem, or confidence. This change in self-perception might affect their ability to engage in sex confidently, have self-confidence in their gender expression and gender identity, and their ability to have emotional intimacy with their partners. Heart disease can strain intimate relationships in many ways, including the ones we just discussed. I don't know if any of you have seen the show Grace and Frankie, but they explore this topic a little bit. In the show, a married couple, Robert and Saul, have conflict after Robert has a heart attack, and Saul feels all this pressure to monitor Robert's diet and exercise very intensely out of fear and love for Robert and his health. And Robert ends up feeling really controlled by Saul and like he's Saul's patient, causing strain in their relationship. Robert and Saul would also be a really good example of what could happen at post-op or follow-up appointments. They are an elderly gay couple, and from ageism or homophobia, an HP might think they're not sexually active or be too uncomfortable discussing sex with them and not bring it up. This could cause them to engage in sex in an unsafe manner, not following precautions accidentally, or it could cause them to not engage in sex at all because the HP didn't discuss those emotional and physical barriers that might come up and teach them ways to overcome them. Cancer is also a really big one with sexuality, not only because of its prevalence, but because of the many ways that cancer treatment and recovery affect so many different aspects of sexuality. Cancer treatments such as surgery, chemotherapy, radiation therapy, and hormone therapy can cause many physical and emotional changes that affect sexual function, mental health, and body image. These changes include fatigue, pain, sensory changes, loss of libido, vaginal dryness, erectile dysfunction, dyspareunia, which is pain during sex, and changes in genital sensation. Surgeries, scarring, weight changes, hair loss, or alterations in body function due to cancer treatments can affect body image and self-esteem, both of which affect gender expression and sexuality. These changes may impact individuals' confidence and comfort with intimacy and can make it challenging to find the energy and drive to embody one's self in a fulfilling way, their sexual self in a fulfilling way. Certain cancer treatments, especially those affecting reproductive organs or involving hormonal therapy, can actually induce menopause in women or people with vaginas and cause hormonal imbalances. These changes can lead to symptoms such as hot flashes, vaginal dryness, and changes in sexual desire. This is only exacerbated for non-binary or trans people. For example, if a trans person is taking gender-affirming hormones, they may have to stop these hormones while undergoing cancer treatment or completely, which can be incredibly distressing. Coping with a cancer diagnosis, treatment-related stress, anxiety, depression, fear of reoccurrence, and concerns about body changes can affect one's emotional well-being, which may subsequently impact sexuality, including sexual desire, desirability, ability to be intimate, and so much more. Cancer can also strain intimate relationships due to the physical and emotional challenges it presents. Communication barriers, changes in roles within the relationship, and managing stress can impact intimacy and sexual connection. Some cancer treatments can affect fertility, leading to concerns about future reproductive capabilities and family planning. Diabetes is another common condition that negatively impacts sexuality. Nerve damage associated with diabetes can affect sensation, leading to reduced sensitivity in sexual organs, making sexual arousal and pleasure more challenging for both men, women, and beyond. That sounds like to infinity and beyond with gender. This may cause difficulty achieving orgasm, for example, due to nerve damage in erogenous zones. HPs can step in here because they can help people explore, and this is the same for cancer, help people explore new erogenous zones and help them find new ways to be intimate and experience sexual arousal with their partners. People with penises who have diabetes may experience difficulty achieving or maintaining an erection due to nerve damage or neuropathy, or blood vessel issues like vascular problems caused by high blood pressure levels. People with vaginas who have diabetes may experience vaginal dryness, leading to discomfort or pain during intercourse. This dryness can result from reduced blood flow and nerve damage. Diabetics may experience a decrease in sexual desire due to hormonal imbalances or psychological factors associated with managing diabetes. Diabetes management can be stressful and may lead to mental health challenges like depression or anxiety, both of which can affect sexual function, desire, and relationships. Some medications used to manage diabetes or its complications might have side effects that impact sexual function, like libido. As you can see, there are many themes across all of these conditions, such as sexual dysfunction, strain on relationships, mental health challenges, all of which that affect sexuality. Although the treatments and precautions will vary from one condition to the next, it's really good to be aware of these themes so that we can anticipate the issues that clients might face and provide them with resources and education they need to successfully manage their sexual health. So it's important to know the laws and policies that impact healthcare, as it dictates what services our clients do or don't have access to regarding their sexual health and therefore their well-being. Additionally, mental health is a major factor in sexuality, and as health professionals, it's our duty to understand how the laws and policies in our country and in our states are affecting our clients' ability to access mental health services. We've made improvements in the way our federal government and country protects people with mental illness and approaches mental illness with acts such as the Americans with Disabilities Act, Affordable Care Act, and the Mental Health Parity and Addiction Equity Act. Some of these acts include sexuality, but others don't address it. The passage of the ACA, Affordable Care Act, in 2010 expanded access to health insurance coverage, including coverage for preventative services related to sexual health, such as STI screenings, contraceptive services, and prenatal care. The ACA also expanded mental health and substance use disorder services and coverage through Medicaid expansion and the inclusion of mental health services as essential benefits in insurance plans sold through the health insurance marketplace. Insurance is a hard word for me to say. I don't know why. It's hard to spell too sometimes. While the Americans with Disabilities Act, ADA, does not specifically address sexuality, it does prohibit discrimination based on disability in various contexts. This can indirectly impact individuals with disabilities who might face discrimination, unequal treatment, or inaccessibility to sexuality-related services in areas covered by the ADA, such as employment, education, or access to public services. So for example, ADA ensures someone can access their doctor's appointment where they can then get sexual health services. The Mental Health Parity and Addiction Equity Act, MHPAEA, of 2008, requires health insurance plans to offer mental health and substance use disorder benefits on par with the way they treat medical and surgical benefits, which is awesome. However, this does not mean that every state and insurance company follows this law well, nor does it mean that people have equitable access to these services, even though they have the legal right to them. Health Insurance Portability and Accountability Act, HIPAA, allows clients to have more trust in what they share with an HP, including their information about their sexuality, and ensures that it's going to remain private. Under HIPAA, we can remind our clients of their privacy standards, of the privacy standards we hold ourselves to, so they know that their highly personal information will be protected. Due to the medical trauma experienced by clients of color and LGBT plus clients, among others, it will take a lot more change in relationship building to regain clients' trust. We have a lot of work to do to build off these policies, laws, and acts and ensure they're being upheld. As of now, the regulations on sexual health coverage are very minimal and only address a small slice of sexuality, mostly biological aspects of sexuality like contraceptives. But we can do our part to take steps in the right direction in our practice to expand coverage. I'm a little cold. I'm going to close the door. 1 second. Okay. So we've already discussed why it's important to know your state sexual education policies during our PEDS lecture, but I also wanted to urge you to be aware of your state's other reproductive health policies, as it has a very significant impact on your future clients' physical and mental well-being. Reproductive health policies include measures related to abortion, contraception, sexual education, prenatal care, and maternal health services. And I'm using terms like maternal health and so on because that is what is used in all the policy, but hopefully we can get those terms to be more gender inclusive. Each of those topics could honestly be a lecture in of themselves, so I'm just going to focus in on abortion. So the Roe v. Wade Supreme Court decision established in 1973 legalized abortion in the US. The ruling acknowledged a person's right to choose to have an abortion without excessive government interference, upholding the constitutional right to privacy under the Due Process Clause of the 14th Amendment. The decision significantly impacted sexual and reproductive rights, granting individuals more control over their reproductive health and choices, thereby influencing decisions related to sexual activity, family planning, and a person's autonomy in matters concerning their bodies and reproductive health. Now that Roe v. Wade has been overturned, many people do not have access to safe and legal abortion services, which significantly affects people's reproductive choices, family planning decisions, body autonomy, and human rights. This will lead to increased health risks for those seeking abortion services, and in marginalized populations, particularly those with limited resources and access to healthcare, face disproportionate challenges, intensifying existing health disparities. Moving on to forced sterilization. This occurred via state-sponsored programs in which health professionals forcibly sterilized individuals, primarily targeting marginalized groups such as people with disabilities, minorities, and those deemed unfit to reproduce. In other words, forced sterilization was a form of ableism and white supremacy. This highly unethical practice occurred predominantly during the 20th century, with the most recent documented case that I found in my in our text to be in Oregon in 1978, involving the forced sterilization of a Black woman. It was often justified under eugenic ideologies, aiming to prevent certain groups from procreating based on flawed beliefs about genetics, not even flawed, absolutely incorrect beliefs about genetics, intelligence, and societal standards. The Nazis actually cited California's sterilization laws when proposing their own program in 1933. Although forced sterilization is no longer practiced in the US, it has created distrust in healthcare systems, particularly among communities that were disproportionately targeted, such as people with disabilities, mental health challenges, and minorities. Modern eugenics is a whole other topic that we could do a full lecture on that we don't have time for. But if any of you are curious to learn more, feel free to reach out. I'd be happy to share information. The traumatic legacy of forced sterilization contributes to ongoing concerns about body autonomy and informed consent, especially in matters related to reproductive health and sexuality. It has led to persistent issues of systemic discrimination, marginalization, and a lack of access to comprehensive healthcare services, impacting individuals' ability to make informed decisions about their reproductive and sexual health. By being a trauma-informed health professional dedicated to providing people with accessible, reliable, and relevant sexual health information, we can contribute to healing and be a part of the change required after such horrific atrocities. The Me Too movement has prompted greater awareness, conversation, and calls for accountability regarding consent, boundaries, and respectful behavior in sexual interactions. It also empowered people to speak out against instances of sexual abuse, fostering a shift in societal attitudes towards addressing power dynamics, respecting boundaries, and advocating for greater equity and safety in sexual relationships and environments. Me Too continues to be a platform where our society gets to work out what is not acceptable, what is, which will be a ever-evolving debate of what is or isn't acceptable and what our standards are. As health professionals, we work with people during vulnerable states, and they look to us for support, information, and healing. There is a power differential that we really need to acknowledge and be respectful of as health professionals. Ensuring we give our clients informed consent, body autonomy, frequent check-ins are all great tools for ensuring clients feel safe and respected under our care. So, pop culture and media representation of sexuality. Portrayals of sexuality in movies, television shows, music, literature, and other forms of media have shaped societal attitudes and norms surrounding sex, relationships, gender roles, and body image. Media representations often influence perceptions of beauty ideals, romantic relationships, and sexual behaviors. These perceptions can either help or hinder our and our clients' understanding of sexuality. It's good to pay attention to what media we consume and what biases we may be harboring based on our consumption. The rise of social media platforms and technology has affected how people connect, communicate, and express their sexuality, such as dating apps and sexting. The Black Lives Matter movement's roots can be traced back to Black LGBT+ activists, poets, and speakers. These people challenge conventional Black activism that marginalized gender and sexual freedom. While the BLM movement primarily concentrates on issues related to racial justice, it indirectly intersects with sexuality. There is an article written by Tatiana King. She's a Black writer, graduate student studying sex therapy, sex blogger, and she also has a website that advocates for sexual and mental health. I wanted to read you an excerpt from her article as I think it really communicates the intersection between sexuality and the BLM movement well. So here is the excerpt. I'm reading straight from her article, and you can click on the article there at the link. Growing up, resources and representations of navigating sexuality as a Black woman were slim to none. On the rare chance that there was representation, it was confined to traumatic experiences and harmful stereotypes. At the same time, it was common to see people within my own community use respectability politics to label young women, in particular grown or fast, for any act or sign that might appear too sexual for their liking. By taking up space in conversations about sex, I wanted to show that Black sexuality is powerful, that there's a sense of freedom that comes with radically embracing our bodies, sensuality, and eroticism. Black people have always been viewed by white people with both amazement and disdain because of our bodies. Historically, we were stolen, assaulted, and used as if we only existed for other people's entertainment and consumption. And despite all of this, we now dare to show that we're more. We dare to dream, reimagine, and fantasize about what living a free and sexually liberated life means for us. Sexual freedom may look different depending on the person. Some may feel empowered by abstaining from sex to focus on their life goals. Others may feel more empowered by reclaiming sexual slurs that are specifically aimed at marginalized communities. Regardless of how sexual freedom looks for us, we continue to embrace our sexuality and our bodies because our pursuit of pleasure and empowerment shouldn't equate to sacrificing our humanity. Sexual freedom fits into the Black Lives Matter movement because Black Lives Matter goes beyond conversations about Black pain and survival. It is also about showing that our society actually gives a damn about our holistic experiences. It is about releasing the Black body from shackles of suppression and exploitation disguised as visibility. It is about self-agency and being unapologetically who we are without fear of being confined to a box. Thank you for listening to her words. I encourage you to check her out. She's a real cool educator. So now we're moving on to barriers and key facts identified in the literature. One of the barriers I saw a lot in the literature was disability-centric care. When an HP is providing disability-centric care, it means that they are laser focused on the condition or disability and not on the client as a whole person. When this occurs, sexuality gets left out as the attitude of the HP. When this occurs, sexuality isn't addressed because the attitude that the HP has is they have more important things to worry about than sex, which is pulled from a Lung 2021 article. However, sex is often one of the first things clients think about, particularly with new injuries and illnesses. For example, people with penises who have a recent spinal cord injury are often concerned about whether they will be able to get an erection. That's from an Owens and Than. Clients with disabilities report that their bodies have primarily been treated in a functional manner, while their emotional needs and desires were neglected. Another barrier identified in the literature is a lack of knowledge, training, and resources. Clinicians express that they don't bring up sexuality because they don't have the necessary training or knowledge. They also express that they are afraid that the client will expect them to have all of the answers. So what Catherine Ellis talks a lot about is it's important to remember that when addressing sexuality, you do not have to have all of the answers in order to bring it up or discuss it with clients. If you don't know the answer, you can save the topic for the next session and do some research, or you can help direct the client to another health professional or resource that will be able to answer their questions. Providing unbiased, trauma-informed, and compassionate response to our clients with their sexuality-related needs doesn't require extensive sexuality knowledge. It just doesn't. Taking this course is a really great way and a first step in increasing your knowledge and training in addressing sexuality. And if you want to address it more in depth in your practice, there are profession-specific continuing education courses you can take. And you can also advocate that your future employer invests in training you and your coworkers on how to address sexuality in your setting. There are many ways to increase your knowledge, in other words. The main recommendation in the literature, though, regarding lack of training and knowledge was integrating sexuality into grad school curriculum, hence making this course. And lastly, personal discomfort. We discussed this one during our PEDS lecture as well, and how cultural, religious, and personal reasons led to HPs to feel too uncomfortable to address sexuality with their clients. So taking this course and exposing yourself to different elements of sexuality via podcasts, movies, books, Instagram accounts are great ways to increase your comfort. Another recommendation I have is to practice talking about sexuality with your friends, practicing words that make you uncomfortable, and get your wiggles out with people that you trust. That way, when you talk with a client, you'll know how to work through those feelings in real time rather than freezing up and potentially causing clinical harm. So it's that time. We're going to take a 5 to 10 minute pause to answer these questions about bias. So, what exposure have you had discussing sexuality in your adult life? This could be amongst friends, with parents, or with health professionals. For the next question, this might be a disabled person, an elderly person, or a queer person. So you can just think on that and respond. And for the last question, with increasing your comfort, I want you to pick at least 2 things outside of this class that you could do to increase your comfort levels. So let's pause now, take a pause, and we'll be right back. Okay, we are back. Thank you for taking the time to reflect. If you realize you haven't talked about sexuality much in your adult life, I encourage you to find people you can trust to practice discussions with. I also encourage you to expose yourself more to whatever kind of person makes you feel the most uncomfortable discussing sexuality with. And I mean it. If you just put in a couple of cumulative hours exposing yourself, it can prevent you from accidentally offending a client or causing clinical harm in real life. If you find a cool resource to increase your comfort levels, please share it with the class or email it to me. So being in a relationship when you have a disability has the same elements of any relationship: shared interests, developing trust, love, habits, fight cycles, sexual routines, meeting families, the whole gambit. Where the problem typically occurs is that our country, society, culture, systems, all of it is built for able-bodied people. Disabled people do not grow up seeing people who look like them fall in love in movies. They don't see images of disabled bodies having sex. They don't get sex ed even that includes how to engage in safe sex with a disability. The dating scene has countless hurdles, including stigma and bias. The list goes on and on. Relationship dynamics, when one or more partners have a disability, does change the relationship dynamic. Partners may need to adapt to changes in sexual practices like safe positioning, more communication surrounding intimacy, such as lubrication and timing with medications, and emotional support, as well as logistical or physical support. Luckily, with the internet, disabled people have access to more disability-specific information and can watch helpful YouTube channels of people navigating life and sex with disability, like shout out to Squirmy and Grubs and Sitting Pretty Lolo, great accounts. But that's limited to people who can access the internet independently or who have a trusted person they feel safe with who can help them explore this information, which not everyone is lucky enough to have. Even if you can access it, who's to know if the websites and articles they're reading are evidence-based and accurate? That's our job. One of the themes in the literature is next topic is body autonomy, which was one of the themes in the literature. From a young age, people with disabilities aren't asked for their consent before touch. Health professionals readjust, touch, or manipulate disabled bodies without their consent. Aides reposition them without consent. People grab their hands to lead them, or even direct their wheelchair without their permission. There are countless examples, but after thousands of these encounters, the messages being sent to people with disabilities is that they do not have autonomy over their body, and potentially that able-bodied people have the right to override their autonomy. As we've discussed, people with disabilities often encounter barriers in accessing sexual health information, resources, and services due to physical accessibility issues, lack of inclusive resources, or healthcare provider biases. Lack of abortion access is a big example of this. Roe v. Wade significantly impacts people with disabilities. For many, pregnancy could actually mean death. For instance, Flora Ellis, who is featured in a Time magazine article, has a connective tissue disorder that poses the risk of organ rupture during pregnancy. Flora's sexuality has been significantly impacted as she lives in Oklahoma, a state that does not allow for abortions. So when Flora wants to have sex with her partner, she has to risk her health and potentially her life every time. The American Association of People with Disabilities, the AAPD, wrote in a statement in response to the overturning of Roe, stating, "Policies that restrict access to abortion will drastically exacerbate threats to the autonomy, health, and overall well-being of disabled people." Well said. So now let's focus on our special topic this week, mental health and trauma-informed care. Chug some water. So here I've listed some major ways that mental health impacts sexuality. Medication side effects not only impact sexual function like libido, but can also impact social skills and energy levels. These can drastically impact a person's ability to maintain healthy relationships with themselves and with others. Communication challenges and low self-esteem put people with mental illness at a risk for unsatisfying or even harmful sexual experiences, as they might have challenges articulating their boundaries, saying no, or asking for what they desire. Interpersonal challenges can include sexually risky behaviors, such as unprotected sex with a stranger while intoxicated. People with mental illness also experience higher rates of sexual assault. My hope is that if health professionals start having more preventative and educational conversations with people who have mental illness about sexuality, sexual assault, and other harmful sexual experiences could be reduced. Literature has also shown that health professionals sometimes discourage people with mental illness from having children, don't help clients manage their medications to allow for pregnancy, and encourage abortion. This often comes from a place of stigma and bias from the health professional, undermining the client's ability to be a good parent while living with a mental illness. Additionally, Ellis and Unko discuss in Chapter 9 of their sexuality textbook that LGBT individuals have disproportionately high rates of suicidal ideation due to the trauma they face from society. They highlight the importance of understanding that being LGBT is not the cause of mental illness, but rather the result of exposure to homophobia and societal devaluation. So, speaking of trauma, let's talk about it. Most of you know what trauma is, but to ensure we have a shared understanding, I wanted to define it here. Feel free to pause the video to read this definition. I'll give you a second. Okay, moving on, 3, 2, 1. There are also different types of trauma. Not all of them are listed here. The first here is structural trauma. An example of structural trauma might be the Tuskegee syphilis study, which involved deliberately infecting Black men with syphilis without their consent for observation purposes, further fueling mistrust in medical professionals within communities of color. Sexual violence is also a common example of interpersonal trauma. For someone with a history of sexual trauma or mistreatment, the idea of a physical exam or even a discussion about sensitive areas or topics may be extremely challenging due to fear or trauma response. In Ellis and Unko's chapter on trauma, chapter 9, they discuss the decades of marginalization and targeted violence against LGBT plus individuals, the trauma of seeking medical care as a queer person or person of color, and the endured trauma of having to maintain traditional gender roles and expectations. This might lead to a person to internalize messages about their value, believing they aren't worthy of joy, causing intrapersonal trauma, which can sometimes be self-harming behaviors, but just internalizing that stigma and phobias. Trauma is very prevalent, with 70% of adults having experienced at least one traumatic experience. There is also a direct correlation between trauma and physical health conditions such as diabetes, COPD, heart disease, cancer, and high blood pressure. And as we've covered, many of these conditions impact sexuality. Essentially, more people than not have experienced trauma. So we should all be learning how to provide trauma-informed care with those stats. Unfortunately, sexual assault is a common cause for trauma, and it's notoriously underreported. Not only does sexual assault negatively impact sexuality, it's incredibly costly. Recent estimates put the lifetime cost of rape at $122,461 per survivor, including medical costs, lost productivity, criminal justice activities, and other costs. It makes you think about what do people do if they don't have the means to pay for care or don't have access to quality therapy, lawyers, and so on? What if you have a disability and people aren't even cognizant of your sexual healing post-assault? What does this do to someone's overall health and well-being? So take a moment to soak in this information about ACEs if you're unfamiliar, pause if you need to. ACEs are categorized into 6 parts, and you get a point for every category you've experienced. The categories are physical abuse, emotional abuse, sexual abuse, physical neglect, emotional neglect, and household dysfunction. Having a high ACE score predisposes you to things like poor immune functioning, higher risk of mental health challenges, and higher rates of substance use. This can all negatively impact sexuality, and due to its prevalence, we need to do our part of meeting clients where they're at with compassionate, trauma-informed care. So what is trauma-informed care? Trauma-informed care recognizes the widespread impact of trauma and emphasizes creating an environment that fosters safety, trust, and collaboration for clients. It acknowledges the prevalence of trauma among patients and seeks to understand how it might affect their physical and mental health. This care model emphasizes sensitivity, validation, and empowerment, aiming to avoid re-traumatization and support clients in their healing process. The key principles of trauma-informed care are really good tools to use when you're addressing sexuality with the client, whether they have trauma or not. The first is safety. This means ensuring physical and emotional safety for both staff and clients. and creating a secure and trustworthy environment. This could look like encouraging a parasympathetic response or asking for consent before you touch a client each time and every time. 2 is trustworthiness and transparency. This means building trust by maintaining clear and open communication, being consistent, and keeping appropriate boundaries. An example might be orienting a client to the session plan, including timing and verbalizing each step along the way. It could also look like orienting the client to the physical space and ensuring they know how to exit the building if needed. The third, peer support, recognizes the importance of peer support and leveraging it to foster connection, empowerment, and healing. This could mean referring your client to a local sexual assault survivors meetup group, for example. The fourth, collaboration and mutuality, promotes collaboration between staff and clients, valuing their input and experiences, and recognizes the importance of shared decision-making. This could look like asking a client what they've tried in the past to remedy their ailment and understanding their preferences and priorities before prescribing a new remedy. Empowerment, voice, and choice supports clients in developing a sense of control, autonomy, and empowerment in their healing process. An example might be giving the client multiple options of where to sit in the room, or asking the client what they would like to focus the session, what they would like the focus of the session to be, when possible. Cultural, historical, and gender issues asks you to recognize and address the impact of history, culture, and gender on trauma experiences, and promoting cultural sensitivity or humility and inclusivity in services. An example might be not making assumptions about a client's sexual orientation or the names they have for their genitalia or chest area. For example, the term breasts might be incongruent with their gender identity, so you can ask what they call various body parts rather than assuming. Positive sexual experiences are associated with various positive outcomes, such as reduced substance use, decreased depression, higher self-esteem, increased community involvement, and reduced delinquent behaviors. Engaging in sexual activity has been linked to lower risk and incidence of psychiatric illnesses, depression, and suicide. Research also suggests that positive sexual experiences contribute to overall physical and psychosocial well-being. Additionally, sexual activity and orgasm have been shown to reduce stress levels. In a study analyzing women, positive sexual experiences and masturbation were found to enhance self-esteem and body image. Communication about sexual preferences and negotiation of boundaries can improve perceived relationship quality and increase contraceptive use. Developing a comfortable sexual or gender identity has also been associated with increased self-esteem and empowerment among youth. Sexuality is considered a key determinant of well-being and can be used as a tool for healing. For example, cancer is a condition where the thinking of when someone is battling cancer, are they really going to be thinking about sex? Research suggests that yes, cancer patients do in fact think about sex and really want their health professionals' help in navigating it. There's actually a great podcast called Dying for Sex that I really like, created by this woman who documents her best friend's sexual journey while battling severe breast cancer. So, recommended. Engagement in sexuality-related activities can be used as a tool for healing from us, mental health promotion, and physical wellness if we are able to get over our squickiness about it. Ensuring clients can engage in sexuality in a fulfilling manner should absolutely be on our checklist with every client we work with. So here's our optional list, optional. First off, we have a YouTube series called Queer Sex Ed by the It Gets Better Project. Their whole channel is great, but this series allows you to hear the lived experience of queer people, including queer people with disabilities, discuss their experience with sex, dating, and relationships. The next is a good article on trauma-informed care if you would like to learn more about that. And if you're more of an audio person, there's a podcast episode interviewing a sexual assault and trauma expert on healing from sexual violence and being a trauma media consultant for movies and TV, which is interesting. And lastly is like a very short little video on disability justice and transformative justice, both of which are incredible topics that we don't have time for in this course, so I just popped them in there. So thank you so much for showing up today. You did it. You rock. I'm proud of you. It's been a pleasure. And here are our references. I will see you guys next time. Au revoir.